Well, good morning. I have 9 a.m. and that's when we get started because we know your time is valuable. We want to make sure that we get you in and out of here on time because we have a very great echo planned for you today, talking about some reimbursement issues. July 28th, who would have thought? We're still working, a lot of us are still working from home, and so it goes, right? And here we are, the end of July, on the verge of August. So hope everyone's doing well. Thank you for attending the Telemedicine Echo. This is a Heartland Telehealth Resource Center and Missouri Telehealth Network partnership. And we're offering this echo for providers in Missouri, Kansas, and Oklahoma. And we've addressed topics such as technology, operations, clinical operations, legal and regulatory, and evaluation. And we really need your input. And if you wouldn't mind doing this, as letting us know what else that you want to hear from us. We want to make sure that you are getting what you need out of these echoes, and we are most happy to oblige. So I'm Janine Gracie, Project Director for the Heartland Telehealth Resource Center, and I have the honor to moderate these sessions. But before we get started, I'd like everyone on this echo to make sure to name or rename your echo screen to show your first, your last name, as well as the state that you are representing. We want to make sure that we're answering your questions according to the state that you're in. So if you wouldn't mind doing that for us, and it's really pretty easy. You just have to right click on your photo or your name and hit rename, and there you can rename your screen. If you could do that for us, that would be awesome. Thank you so much. All right. So now we will have the hub team members introduce themselves. We're minus a couple today because of an important meeting in Missouri. And so Rachel and Karen are not with us. So we're going to start out with introductions of the hub team and have Evelyn begin.
Good morning. Nice to see everyone this morning. I'm Evelyn Nelson. I'm a telepsychologist at University of Kansas Medical Center and PI for the Heartland Telehealth Resource Center.
Great, thank you. And Robert?
Hi, I'm Robert Strauss with Katie School of Medicine Department of Pediatrics and work with the HCRC.
Thanks. And Tim?
Good morning. I'm Telehealth Manager at OSU Center for Health Sciences, and I work with HCRC in Oklahoma.
Great, thank you. And Heather?
Good morning, everyone. My name is Heather Hagan. I'm a telehealth analyst at OSU CHS.
Thanks so much. This hub team works to provide your echo topics and get the speakers and that type of thing. So they're behind the scenes and also the experts on this echo to answer some questions should we need them. So, well, we are nearing 30 participants, and so we are going to forego those introductions, but the way that we would like for you to introduce yourself is to do that in the chat. So please provide your name, your title, your organization, and your state, and I'll give you a few minutes to do that. All right, and let's see if we have anybody by phone. I have a 618 number. Would you like to introduce yourself so we know who's here?
Hi, this is Jill Sigliana with Memory Care Home Solutions in St. Louis, Missouri.
Wonderful. Nice to have you here. Good deal. Okay, now that we've done that, we are going to make a few announcements before we get to our guest speaker. So, of course, if you've never joined an echo before, an echo is a really relaxed atmosphere that we just use first names only. So let's forget all of our titles and address each other by first names only. In this echo, if you have a question, we like for you to use the chat feature. And if you go down to everyone, like where it says to everyone, that's what it should say right now. And then go down to Ask Joe Kingsbury. You can ask your question and in the chat feature to Joe Kingsbury, and he's waving at you, and he's a friendly guy. Don't be scared to ask questions. We'll get to those and make sure that we try to get all of those questions answered for you during this echo. Also, it's important that you know that you may also answer or ask your question by video. So all you need to do is raise your hand, keep your video on mute until recognized, and then ask your question. And then, you know, just introduce yourself again so we can get to know you. The presentation and any accompanying materials will be available on Box. It's important that you take a look at that. And if you can't get into that, Lauren or I can help you navigate your way through that system. But that's where all of our echoes are, and it's, you know, a wealth of information in Box. The value of the echo is in the cases. And so please, if you want to volunteer a case, you may do so. It could be anything from, hey, we're having trouble with this telemedicine platform, or we don't think that we can expand this certain platform for telemedicine, and how can we do this and be successful. And then we all chime in, and we come to some kind of conclusion, and most usually it's something that's very workable. So thank you for that, and we are now ready to introduce our guest speaker. Richelle Marting is a clinical assistant professor at the University of Kansas Medical Center. She has been on our echo before, and overwhelmingly you asked to bring her back. And so she is here again to talk about some reimbursement issues and policy issues and that type of thing. And it's probably going to be more of a question and answer type echo today. So I'm just going to let Richelle make a few opening remarks, and she has a few slides, and then we'll get into the Q&A.
All right, thanks, Janine. All right, can you hear me okay?
Yes, we can.
Great, great, okay. Well, let me see if I can share my screen here. All right. Everybody see those slides? Great, okay. I've got them on a second screen, so I'm gonna be looking off to the side here while I talk with you. So the last echo session I attended, it's probably been about a month now, more or less. I lose track of time. And we talked about some of the different telemedicine services and the difference between telemedicine, the way that term is defined for Medicare, and all of the kind of technical nuances to what it means to provide telemedicine under the Medicare benefits, what kinds of telemedicine services are covered under Medicare, kind of in a normal environment versus a few that are added during the public health emergency period. And then some other non-face-to-face services that I think of almost in the bucket of telehealth or telemedicine, but they don't necessarily fall in the very technical requirements of telemedicine under the Medicare program. So we took a look at those different services and some general coding guidelines, things that have changed under COVID rules. So what the group had asked me to talk about just very briefly before we open up for questions and answers, or what is the status of the public health emergency and some of the relaxed rules for telehealth and telemedicine that we saw when the public health emergency was announced. So that's what I wanted to go over just really quickly from a federal and then the state levels, also so you can get an idea of what those relaxed requirements are during the status of the public health emergency, and then kind of what we expect to see when and if that emergency period ends and the emergency status at the federal or the state levels, it changes. So let me start by going through my screen here. There we go. To some of the issues and the status changes at the federal level. So this is just will be a really quick 4-month history lesson here. What we had at the federal level were really 2 declarations that were really important to trigger some of the waivers that we saw with respect to telemedicine. There was both the President's declaration of an emergency, national emergency, and that was March 13th. But prior to that, we had the Secretary of the Federal Department of Health and Human Services, actually all the way back in January, declare a public health emergency. And those 2 declarations were really important because it triggers a set of statutes that give authority to both the President and to the Secretary of Health and Human Services to change some rules to address the public health emergency or the national emergency without going through the normal rulemaking process, which we know can take a really long time to make anything happen. So what the Secretary of Health and Human Services did under that January public health emergency, it was retroactive back to January 27th, and then it's been renewed a couple of times now, as recently as last week. And there was some question about whether that emergency declaration would be renewed again. If it was not renewed, we would be talking today about what the impact of that was, what rules have been rolled back versus what's staying. But fortunately, that was renewed, so a lot of those rules are still in place today, a lot of those waivers. So one of the things we look at whenever there's an emergency declaration, the waivers that we see only apply to the geographic area where the emergency exists. So if you see a hurricane, or if you see wildfires in California, typically the emergency geographic area is limited to where that natural disaster has occurred. The significance of the President's emergency declaration in March is it made that geographic area the entire country, so that the waivers we're talking about are nationwide and not limited to any particular geographic area like New York, where COVID was really bad really quickly. So under the public health emergency that the Secretary of Health and Human Services declared, it gave us several waivers related to telemedicine. And I'm giving you dates because as I go through the states, you're going to see each of these is just a little bit different as we get into state-specific rules. So March 13th was an important date at the federal level, and the Secretary of Health and Human Services exercises authority to create some waivers of rules that are otherwise in place for telemedicine services. And those would be retroactive back to March 1st and services provided back to March 1st. The important thing to remember with these waivers is that they were only effective for Medicare, Medicaid, and S-CHIP services. And they weren't, they don't eliminate the rules. They waive the Secretary's right to enforce them for a period of time. So the rules are actually still there. And I think that's important because there are some waivers of like HIPAA security rules that we can use certain platforms and not worry about enforcement from the Office of Civil Rights and other federal agencies right now when we're providing telemedicine. But those waivers were only the Office of Civil Rights. And there are other agencies that can enforce some of these rules, like the state attorney generals, who did not necessarily waive their right to enforcement. So it's kind of a catch-22. Like, it's not a blanket, you're good to go, because there are other enforcement agencies to think about. And when I say that some of these waivers apply to Medicare, Medicaid, and the Children's Health Insurance Program, that's important to keep in mind because it gave us some payment flexibility under those programs, but not a full and blanket legal right to proceed with some of these activities. So let me give you an example of that. Under this March 13th waiver that was retroactive back to March 1st, Medicare, Medicaid, and Children's Health Insurance said to be paid for telemedicine services under those three health insurance programs, a provider doesn't necessarily need to be licensed in the state where the patient is located. That is typically a requirement under Medicaid, Medicare, and Children's Health Insurance. And those three programs said, for now, we will waive our enforcement of that requirement. We will still pay you if you didn't meet that particular requirement. But what that did not do is change all of our state's laws that require a provider be licensed in the state where the patient is located. So it allowed us to be paid from a Medicare perspective, but we could still have licensing issues at state law if we weren't following those requirements. So keep that March 1 date in mind, because when we'll look at the individual states, we'll see how that's a little bit different than what we have at state laws. So the status of our federal emergency situations and declarations, well, I guess let me back up to some rulemaking requirements over here on the left. Through the initial waivers, as well as some interim final rules, they kind of skipped over our normal proposed rule, public comment, final rulemaking process, and instead the secretary just issued some rulemaking to make changes that were needed to address the public health emergency. Among those related to telehealth, the secretary added to the list of services that were otherwise covered as telemedicine in a non-COVID environment. So down here, if you look at the 1, 2, 3, third kind of bold item, it says telemedicine codes, and there's a link there. You can click on that link to see what the current list of covered telemedicine services are during the public health emergency. If you want to compare that, there's a tab on that spreadsheet that will identify which ones were added just for the scope of the emergency versus which ones are permanent telemedicine services that are covered even outside of COVID. And I think that's a little bit instructive to keep in mind on what could get rolled back when and if the public health emergency or the nationwide emergency declarations are not renewed or revoked or terminated. So we're adding to the types of things that can be done via telehealth. A lot of the geographic restrictions are removed. So one of the typical limitations of traditional Medicare telehealth is that it has to be done for a patient who's in a rural health area. And there's this whole technical definition of what it means to be in a rural area. That rural health component was removed for the duration of the public health emergency nationwide, as well as relaxing some of the locations where the patient can be located and where providers can be located. A really important one of those is that the patient can be located at home right now during the public health emergency, where normally for Medicare, the patient being at home is not an eligible originating site for telemedicine services. And on the flip side, providers can be located at home with the rationale that if a provider is quarantining because of possible exposure, we still want that provider to be available if they're feeling well enough to take care of patients and can do that from home. And we don't have to jump through the hoops of provider enrollment and listing the provider's home as a site of service that would get identified on the claim form. So there were some relaxed requirements there. Supervision requirements were relaxed. Phone visits, audio only, were added as telehealth services, where normally we have to have audio-visual communications. And then we expanded the types of healthcare professionals who are eligible to provide telehealth. So the status of that, there's just recently, probably about, I think it was July 16th, so only a week or so ago, a bill was introduced at the federal level that would preserve a lot of these relaxed requirements, getting rid of the rural component to allow telemedicine to be delivered regardless of the geographic area, continuing to expand the provider types that can deliver telehealth services, allowing the patient to be at home as an eligible originating site. Those were some of the components that we kind of expected to see remain even once the public health emergency or the national emergency terminates, that phase terminates. So that's in its very early stages. We don't know how or when that bill's going to progress, but that's something we can keep our eyes and ears on.
Richelle, this is Robert. I hate to interrupt, but I just wanted to say that the senators and representatives that introduced that bill last week had a webinar on it. And the biggest issue that they're facing is the CBO estimates of costs, because the numbers that are out there are so high, especially because what they're seeing during COVID is expensive, right? People jumped into telehealth and they spent a lot of money, and so the cost numbers are high. So they're really asking for better data to try to prove that it wouldn't cost so much to expand in this way. And so just wanted to point out that the biggest issue that seems to be in the way of making this permanent is really some of those cost estimates. So they literally said, if anybody has any better data on costs that can lower the cost estimates for this bill, they would love to see it, because they really want it to pass. And I think there's a huge bipartisan support for passing it. But if it comes back as being too expensive, it's going to be hard to implement. Sorry to interrupt.
No, I appreciate that. And that's interesting too, because one of the federal initiatives in paying for some of these telemedicine services was payment parity, to make sure if you were providing an office visit via telehealth during COVID to reduce exposure and those things, that you weren't going to get paid less. So it wasn't creating a disincentive to provide a service via telemedicine as opposed to bringing the patient into the office. So that might be something we watch too, if payment parity between telemedicine and in-office services continues, or if they try to look at some differential. I could foresee that happening, because when we're paid for our office services, they're valued based on computer equipment in the office and office time and nursing staff to room the patient and all of those different factors. Those overhead costs still exist, but they're different in the telemedicine environment. So it will be interesting to see what data is produced to compare our telemedicine services equally as expensive. Are they more expensive? Are they less expensive? To see how they handle the payment parity between remote versus in-person services.
Yeah, I think the biggest issue is just use. It's very interesting. It's popular. People like telehealth, especially in areas like behavioral. But because people like it and maybe use it, it's sad to say that the problem may be that it's actually more effective in getting healthcare to people, and that's going to cost more.
Right. I mean, if you can see 12 patients in the office, or you could see 20 via telehealth, because you don't have all of the rooming, the checkout, and those other phases of an office visit. Yeah, you're improving access, which is great, but you're also increasing utilization. From a dollar standpoint at the federal level, I think we'll get some attention. Now, so I wanted to just really quickly go through the status of each state. Now, notice here in Kansas, our governor's emergency declaration was March 12th. And so if we went back to the federal, remember it was March 13th, retroactive to March 1st. So retroactive to March 1st at the federal level, you could get paid for a Medicare telehealth visit if your provider wasn't licensed in the state where the patient was located. However, that was not the same time frame that we were allowed to do that under Kansas law. We had the governor's initial emergency declaration, which then gave different agencies the ability to create rules or waive rules based on rules and regulations within each agency's purview. And so we didn't until March 20th, the Board of Healing Arts in Kansas issued some waivers that would have required an in-person evaluation prior to certain scripts and ordering certain services via telehealth. So the dates didn't necessarily match up from a state and federal level. It made this really complicated. Then in April, we had some of the supervision requirements for professionals like nurse practitioners, physician assistants, and the medical record review requirements that we would normally have under supervision agreements and collaborative practice agreements that were waived later on. Right now, we've got that emergency declaration and the executive orders relating to it extended at least through September 15th. So we'll see, whoa, let's back up there. What happens in the state of Kansas there. In Missouri, we had March 13th as well. It was initially set to terminate on March 15th, so we've seen several extensions of that emergency order in the state of Missouri. Delegated to the state Health and Human Services Department in Missouri to waive certain requirements as well. By and large, the Missouri waivers are very similar to what we saw in Kansas. So a face-to-face provider-patient relationship prior to scripts and ordering services via telemed were waived. What we have in Missouri is that they're right now extended through December 31st of 2020. So looking ahead, we've got a little more time to rely on some of these executive orders unless something magical happens to terminate it prior to that. Medical record review requirements were waived, and added professionals who can issue home health orders and those sort of regulatory compliance requirements that were relaxed and expanded to different professionals. And then in Oklahoma, so we're just a couple days different here. We had March 15th was when the emergency status was declared, last renewed on July 10th, so it's also still in effect. And again, I think this is important because some of those requirements from a federal level for Medicare payment, Medicaid payment, children's health insurance payment that were retroactive to March 1st were not necessarily retroactive to that same date in each state. In Oklahoma, we had some modifications that would allow providers that are licensed in an emergency medical compact state to provide services, waive the provider-patient relationship requirements. And down here, the bottom link on the bottom left takes you to a map of different states that are part of the emergency medical compact that kind of makes licensing, reciprocal licensing, much faster and easier. I really like that Oklahoma did that. What we did in Kansas, when the requirement to be licensed in the state where the patient is located was waived, there was kind of an asterisk saying, but you have to notify the Board of Healing Arts. And so there's like a form that you have to fill out and send in all of the provider's information to the Board of Healing Arts, and for that to get approved before that provider can see patients in the state. And then in May, it wasn't until May 30th in Oklahoma that the state said you can actually provide telemedicine to new patients. It's not just available to established patients. So that was a good waiver we got May 30th. So of course, there are many, many other rules, requirements, and waivers at the state and federal level, but at a very high overview, all of the waivers are currently still in effect, and we're starting to see some bills and some legislation introduced at the state and federal level that looks like we may have an opportunity to maintain some of those relaxed requirements, even when and if the COVID public health emergencies, either at the state or federal level, are no longer in effect because they've expired or terminated. So with that, I will open up to questions and do my best to answer them live, but if there's anything that I need to research a little bit and double check and send you sources, I'm happy to take those notes away and answer questions after the call as well.
Well, thank you so much. That was a great review for a lot of us, and definitely something that we can jump off into for some questions. And so, Joe, what do we look like in the question section?
So we just had one roll in, Janine. Is the ability of APPs to order home health temporary or permanent?
So good. Now I'm gonna have to think back which state that was. Was that Missouri or Kansas? That was Missouri. So it is part of one of the agency's waivers, and the agency's waiver is under the authority that's granted to the agency during the term of the public health emergency in the state. So at this time, that's only in effect for the duration of Missouri state's emergency disaster state under the governor's order. So unless and until legislation is introduced or the agency, I'd have to look and see if it's a regulation under the purview of the agency that it itself could issue rulemaking to eradicate on a permanent basis, is a temporary rule that would allow APRNs and PAs to create the home health orders.
All right, Joe, any other questions roll in?
That was the $1 million question. That's all I've got.
All right.
Yeah.
All right, so let's take a look and see if anybody wants to raise their hand and ask a question to Richelle. Evelyn.
Please go ahead, Evelyn.
Great presentation. Thanks, Richelle. We're getting ready to roll out our telehealth again to schools, and kind of looking at a mix of home and school. Are there any regulations or considerations when you look at telehealth to schools?
So from the federal standpoint, we're probably not going to have a lot of Medicare if we're doing it in schools. But what we would want to look at from a state level and even a payer specific level, not so much statutes and regulations as it is payment policies under Medicaid and commercial payers where those telemedicine services could be potentially reported to. Because schools are, from a Medicare perspective, are typically not at an eligible originating site that would be billed to Medicare. So we would then look under individual payer policies to see whether they allow that to be an eligible originating site. I would imagine that as everybody's trying to get back to school, kind of in person, hybrid, online, whatever the districts are doing in the different states, that we will probably see payers, if they haven't already, allow schools as an eligible originating site, but it will be payer specific.
Thank you. We do have another question that's rolled in, and I think this is probably directed at anybody on the hub team. I've been swamped with COVID infection control. Will you please give me step-by-step instructions to set up telehealth?
Wow. Okay. So that it could be an echo and all of it's in its own. So definitely that would be something that I would love to visit with you about and take you through some steps to implement telehealth. But the first thing that you really need to do is look at a platform. If you have an existing platform or if there's something that you can use, and then put some protocols and policies in place. There are a lot of steps that you have to go through in order to get that done, but I would love to visit with you offline for that. So give me a call or shoot me a chat and we'll get together and talk it through.
Janine, this is Richelle. I think the idea of choosing a platform, if one has not already been selected, one thought I would contribute to that is in March and April, when everybody was going from in-person everything to telemed basically overnight, one of the waivers that we saw from the Office for Civil Rights was an enforcement waiver saying if you choose a platform that maybe is not as secure as you would choose or use outside of the COVID situation, that they would waive their ability to enforce violations of the HIPAA security rule at a federal level. And there's a really good guidance, I can send it if it would be of interest to the person that asked this question, on some examples of audiovisual communication that, as long as it's not public facing, meaning you could have a private communication like we're having via Zoom, not FaceTime Live that gets live streamed to a whole community, or Snapchat, or I don't really know all the different social media platforms in detail, but it had to be a private session. That was kind of the only caveat, and as long as you were using that, some of the waivers would apply. That's one of those examples that I kind of put an asterisk on, because the Federal Office for Civil Rights is a major agency of enforcement of the HIPAA security rules. So they waived their right to enforce, but the state attorney generals also can enforce the security rules, and they have not necessarily waived their right to do so. So if you haven't already chosen a platform and you do have some time to put that together, as opposed to being in a very disaster emergency state and that you're trying to do overnight, I would suggest kind of the due diligence of choosing a sustainable platform that will meet those security requirements even after COVID, so that you're not worrying about what the state attorney generals are going to do or a major security breach, but something that's really going to last for you long-term and be a good product even after the emergency.
Yes, that's excellent advice. And what we're doing right now is encouraging people to plan after the crisis. I mean, you know, to make that plan for after the crisis so that you don't have to stop and restart again. So that's really good advice, Richelle. Thank you for that. Any other questions, Joe?
Janine, before we leave that question, I wanted to add in, you know, I've heard you say this many times, and I think because the need is so great, it's hard to pick one thing and start real small. I really appreciated the person who asked the question sharing that we're all juggling multiple priorities with the pandemic, with infection control and all those stresses. So I think really starting real small with the telehealth and building really applies in this situation. And it's the same that we saw with our own health system. You know, in March, it was a few patients per week and now ramped up to thousands per week. But really starting small, I think continues to be crucial.
Yes, definitely. Thank you, Evelyn, for that word of wisdom, because it is important that you don't try to be everything to everyone in the beginning. You've got to start small and realize those successes in order to move on to the next. So thank you for that. Richelle, I have a question. I had a TA voicemail last night, and I have a frustrated Arkansas clinical social worker provider who wants to see someone in Oklahoma. He called Oklahoma's Board of Healing Arts, and they said, no, you can't see your patient in Oklahoma. Now, is that because that they're not part of that compact? Arkansas is not part of the compact?
That's a good question. Let me pull up that, see if I can find that map. They may, in Oklahoma, still have a notification requirement like we have in Kansas. I don't know if this is still showing my screen here. So yeah, looky there, Oklahoma and Arkansas. That's interesting the way, so Oklahoma would allow others who are part of the compact, but they themselves are not part of the compact, it looks like, or at least the last time that this map was updated. So maybe that's something they're working on. But since Arkansas is not, they would probably have to go through board approval and licensing, and there may be an expedited process to get approved, even though you're not under that kind of general automatic exception as being part of a compact state. But yeah,
so that's one of those situations that the state law trumps the federal.
Right, because the federal is only to get paid by Medicare. It's not a licensing statute, it's just a payment statute.
Right.
You have to be licensed in the state still. And what I noticed in Kansas, the initial executive order was focused on the Board of Healing Arts. So only those professions under our Board of Healing Arts, Board of Nursing, APRNs, CRNAs, that's a different board. And that wasn't part of the initial executive order. So it kind of depends on the way the governor wrote the executive order and which agencies are permitted. The way we wrote it in Kansas, Board of Healing Arts was permitted to waive some of those requirements, but the governor didn't automatically give that authority to the Board of Nursing to do the same.
Wow.
Richelle, I think that's an important thing to remember between the three states. I've always described Missouri as being the most open because they have a parity law for telehealth. Whereas Oklahoma, it's probably the most restrictive. And while Kansas is less restrictive than Oklahoma, they're very prescriptive. And so I would recommend that any provider in Kansas make sure that they're spending time on the KMAP bulletins, because while in general, we can say most things have continued that started under COVID. For example, in Kansas, you know, and those of us who saw Nathan Suter's amazing teledental presentation and the things that he's doing with teledental in Missouri, and we're hopeful for Kansas, unfortunately, Kansas has ended teledental through a KMAP bulletin. So whereas most things are extended, you know, they're using this language in Kansas until rescinded now, so they're not even putting a date on it. They did end the teledental codes that they had allowed under COVID. So it's very important in each state to understand the difference and to also be very aware. In Missouri, it's provider hot tips. So if you are a Medicaid provider in Missouri, definitely read through provider hot tips and keep up to date on those. In Kansas, it's the KMAP bulletins. And then in Oklahoma, it's provider global messages. So I would definitely recommend to anyone that has a question about something that they've been allowed to do under COVID, just try to maybe on a weekly basis go into your state and to those 3 places, and they're going to give you a very good idea. The only other thing in Kansas as well is while the KMAP bulletins, of course, cover everything with Medicaid, if you're doing any type of waiver services in Kansas, you should definitely be staying aware of the KDAD's website because they put out policy notices related to waiver services on the KDAD's website. So just wanted to provide an update. And also, I think sometimes everybody feels insecure and they're like, well, what is still allowed and what is ongoing? It's important to know in each of those states that there is a place you can go to where most of the information is and you can stay up to date. So just wanted to bring that up.
Yeah, and that's a really good example of one that's payer specific, right? So KMAP ending payment for teledental, where other payers could, Aetna or someone else could continue to pay for it under their own individual policies. So it's not necessarily something we could say, oh, since the federal public health emergency is still in place, Medicare will still pay for it. Maybe, maybe not. Some of these rulemaking that we've seen is from Medicare on what they will pay for, but they could also rescind it at any time, even though the public health emergency is still in effect. Another example of that is whether telemed is allowed for new patients in addition to established patients. So we have payment rule waivers from Medicare that would allow that, but at any time, Medicare may decide for payment under that particular health insurance program, they're going to go back to just established patients only. And then we see that the state laws have requirements on whether you can provide it to new or established patients, whether you have to have a pre-existing in-person relationship before you provide scripts via telemedicine, that we're going to have to keep an eye on those specific ones as well.
I couldn't agree more. It is, we are going to, and we're even in different situations, right? Missouri parity law, so it's very easier to do telehealth in Missouri, and a lot of what's being allowed isn't dependent on emergency declarations. Whereas in Kansas, that authority was taken away from the governor as part of the deal they made to continue the emergency. So that's what we're seeing with the schools, for example, right? The governor wanted to extend to when schools could start in Kansas, but they had taken away her authority to do that, and the State Board of Education kind of deadlocked on that issue. And so it is, and we are certainly here to provide advice, and I think everybody's excited to have Richelle, your work with us and your expertise, because these questions are going to matter, and certainly the HTRC is here. If you have questions about what's allowed or what's not allowed, the policy side as well as the billing side, we certainly want to please get in touch with the Telehealth Resource Center, and we will help you with your specific questions. Just want to really make it clear that not only in these echoes, but on a daily basis, you can reach out to us, and we're happy to help you find solutions to some very complicated issues.
Yeah, and if there are any of those major questions, what's allowed, what's not allowed at any particular point in time, I'm also happy to provide the link or the resource or the document. So if that's an important service or caveat that you're working under, you know where to check to see if that prohibition or that relaxed requirement or waiver is still in effect or when it terminates.
I agree. So we can give you blanket statements on Medicare. We can give you state-by-state statements on Medicaid. And the other thing to remember is we can help you figure out what a private insurer's policy is, and we can certainly work with you to help those. But the other thing to remember is we can't even speak globally on private insurance, that it's up to each private insurance company. So that question about teledental, right, in Kansas, so Medicaid's a big payer, and the other big payer is Delta Dental. So I don't know whether Delta Dental is still paying for teledental codes. I don't know if they ever did. But if you have a question about that, we can certainly help you find an answer.
Thank you. Joe, do we have any questions in the queue?
We do. I'm a PA in Missouri. If I want to register with the Kansas Board of Healing Arts to provide telehealth to my patients who may be in Kansas at the time of the visit, does my collaborating physician need to be registered there as well?
That is a good question. I know in Kansas they had one of the either executive orders or Board of Healing Arts waivers relax the supervision requirements. My recollection is yes. You would submit, there's a form where you list the providers and you would submit both of your names to the Kansas Board of Healing Arts, but I can double check on that and send that back to the group to confirm.
Great question. Thank you.
That's it, Janine.
That's it. All right. Anyone else have a burning question that they would like to ask Richelle? She is definitely our expert, so make sure that you take good use of Richelle during this time period. Richelle, so did the January in Kansas, the governor extended that to January, but then was it because of the rollback of her order? Now it's the September date?
I say that again about January in Kansas.
So there was a January date, and Robert might be able to give me the specific date.
And that's actually the deal that the governor made on the last day of the legislative session, extended some of the things, and hopefully the most important things, from the emergency through January 24th or 25th. I can't remember the date. The idea is that some of these things, the legislature will come back into session normally around January 8th, and that'll give them the idea was, okay, we don't know how long we want to extend some of this stuff, but we'll at least do it a couple weeks into the next session, so we'll have time to, because she had brought in a special session to kind of deal with some of the needs of the state. So they kind of punted the ball down the field till January 24th or 25th. But as part of that deal, they took away a lot of the governor's authority, right? All spring, the governor and the legislature fought over these emergency declarations. They fought over the governor closing school, a number of things. So she agreed, in order to kind of make a deal, to have her authority curtailed. So she may not declare an emergency. She cannot extend the emergency without the approval of a special counsel of the legislature. So yes, the emergency is extended, but we saw that, like I mentioned earlier, in the last week with the schools, right? She said, declaring emergency, and everybody was talking about it, right? The governor delayed the school start until after Labor Day. Well, when that happened, I said, I don't think, she may say that, but she's got to have the Board of Education's permission. And so then we saw sort of the political issue over the last week, where the Board of Education met last Wednesday, almost a week ago now, and they deadlocked 5-5 on actually delaying the start of school until after Labor Day. So now it's down to local districts, right, making that decision when they're going to start. And so there are a number of issues like that the governor accepted in order to kind of get a deal made to extend. So that's sort of what you're discussing, Janine, is, so there are certain things that are certainly allowed until January 25th. And that's where, when I talked about the KMAP bulletins now saying until rescinded, it allowed a lot of those payment and other rule changes that were made in response to COVID to kind of be as well punted down the field. Sorry to keep using that football reference. So they're saying, okay, well, we know it'll be January 25th for this, but hopefully they'll have 2 weeks to make a deal, which they're not very good at making deals. So we're going to all cross our fingers. I think everybody wanted to extend it further than January 25th because I thought it would take it longer for the legislature to come to a deal with the governor. But we have at least until January 25th for those types of things. So some of this stuff is no longer dependent on the state declaration of emergency. It's dependent on this statute that was passed in the last day of the legislative session. So if you have specific questions about what's included and what's sort of extended until January 25th, we're happy to answer those as well. But that's why you're seeing in those KMAP bulletins until rescinded. And that's an issue. If you see it until rescinded, you can assume that's probably going to at least be until January 25th.
Okay.
Does that answer your question?
Yes, that clarifies things for me. Thank you so much. I have
Robert, that it also depends on whether the rule came about as part of an executive order from Governor Kelly or the governors in the different states, or if it was the governor's declaration of an emergency or the legislature's that then deferred to the different agencies to create their own policies. And so the agencies creating that rulemaking saying we will cover dental telemed or teledental, that the agency itself can change it, or was it part of the governor's executive order saying, I am waiving these requirements, or these executive orders remain in effect as part of this legislative action? So it's really difficult because we've got to look at the source and where that waiver authority came from in the first place for each one of these two.
And that's absolutely true. And one of the things to kind of notice that with is the governor, made some of these requirements in the Board of Healing Arts, right? They were in her executive orders, but the boards didn't necessarily follow, like they were slow. Anybody that knows physicians understands that they really like to have that oversight of PAs, and they'd really like to have a different board oversees that group. So one of the things we saw was a real slow walk of some of those executive orders and requirements to the Board of Healing Arts, for example. And I believe, and this is just me speaking, I don't know, I'm not privy to any conversations. It was very interesting that the governor required some of these things of the Board of Healing Arts. And then a few weeks later, when they really weren't happening, basically just took away their authority and basically took away supervision and a number of other things in a pretty substantive executive order, where she just kind of threw up her hands and said, all right, it's going to happen whether you like it or not, is my opinion of kind of what that executive order was about. But it was a pretty broad executive order that just basically said, okay, I'm tired of waiting. This is all allowed now. But I think that's also why the legislature came back and really pushed back, and why we're in the situation we're in now, where she's had to accept taking a lot of her authority has been taken away even under the emergency.
So do any of our friends in the FQHCs or rural health centers have any questions? I know that they were fast and furious in the beginning, and maybe you guys have figured it out now, but there seems to be a lot of changes with reimbursement and that type of thing. So anyone want to speak out from our FQHCs?
Janine, I would point out that this bill that's in Congress, certainly the rural health clinics and the FQHCs hopefully can provide strong support to that, because one of the things it does do is continue their authority to serve as distance sites, which was a major issue in the provision of telehealth services for both of those type of entities. So that is included to allow them to become permanently distance sites, which is only currently now allowed under the public health emergency. So just to make sure that both FQHCs and rural health clinics know that, because that's certainly a thing I think that they will be strongly supportive of, and need to know that passing this legislation would implement that permanently.
That would be helpful. Joe.
We've got another one. Are any practitioners in Missouri excluded from being allowed to perform telemedicine? What about billing? I hear there is an issue with pharmacists billing for telemedicine.
Okay, so that's a good question. Pharmacists were added for Medicare services. They were not typically allowed to provide telemedicine services outside of the COVID environment. There was an interim final rule, I want to say it was April 30th, I'd have to double check on the date, that added pharmacists as eligible telemedicine providers, practitioners who could provide telehealth services. The first part of that question, you might need to read it to me again. Are there any practitioners in Missouri? Was that
Correct.
Okay, so part of that is also really the limitations on who can provide telemedicine typically come from the health programs or the insurance plans. So that's an example of one where we'd want to look at the Missouri Medicaid program and look at who they are allowing and if it's following Medicare or if it's different, and the major commercial payers that you're using. We know with Medicare right now, pharmacists can, and we've got a bill enacted that would continue to relax the eligible practitioners who can provide telemedicine. If it is passed, that could be a permanent change. And then in the meantime, we look at each individual payer to see if they are or are not allowing pharmacists to deliver telemed.
That's all we've got, Janine.
Is it really? All right. One last chance for a question from anyone as we are nearing the top of the hour and want to be cognizant of the time, knowing that you're very busy. As I'm not seeing any hands raised.
I have a question. This is David Baran. I know that there was concern mentioned early on about the expansion of telemedicine and the increase in costs. But we have a fair amount of data right now that's showing that that's probably not happening. I mean, most of our clinics in our organization have settled down so that telemedicine is about 20% of their volumes, and their pre-COVID volumes, when you combine the telemedicine to the in-person visits, are about the same as where they were before. And then you have years of Kaiser Permanente offering telemedicine carte blanche, and I don't see them struggling with costs or anything because they're a wholly owned entity, so they would be the ones that would be throttling down or have an issue with that. So is there any evidence to support people's worries that telemedicine is going to blow a hole in the budget?
And you want to take that, anybody want to take that question on? I do know that I think it's in, I don't know what data that the committee is looking at. I do know that anytime that we have these kinds of committees at work, that it is important to contact those members and make sure that they know that you may be a resource for that. And especially when they're calling out for that kind of information, that it's important that we contribute to that. So my suggestion would be to look and see if your state has a member on that committee, and if not, a friend of that committee member perhaps that has some influence. But definitely you can always shoot some information to the chair of that committee and offer to be a resource.
Certainly, if there's any health economists or other people that might have good data, it seems really clear that there is cross bipartisan support for expansion of telehealth, making it permanent. But over and over and over, every representative and senator last week in the conference meeting about the bill said, they were basically begging for better data or lower cost data that they could use to kind of counteract, because it seems clear that the CBO estimate is going to come back very high, and that they feel that that's the main thing that could kill the permanent expansion of some of these telehealth services. Things like, if you think about it, removing the rural component, right, which they're saying that doesn't make any sense because people in urban areas need telehealth as well. But you can see that then increases access, and increasing access increase costs. And specifically, if anybody has any good data saying over time that costs go down, those types of things would be very valued, because what they have now is they're going to take the data from the start of the COVID emergency, and they're going to say, okay, we allowed urban, and what did that cost us? And it seems very clear that they're really worried that CBO is going to say, you're permanently expanding this and allowing this to happen in urban areas, and allowing these other provider types, and allowing the distance site fee for rural health clinics and FQHCs is going to add this amount of cost onto the budget, and that if anything kills the bill, that's what it will be. So anybody has any help? Our representatives and senators are asking for it.
But the truth of the matter is, it's that increase in access to healthcare can also reduce the overall cost and increase health benefits for patients. And so yeah, you're right. They're not looking at long term, they're looking at during the COVID crisis. And so sometimes they have to be reminded of that, because many of them sitting on those committees do not have a lot of healthcare background. So
and that's where I think this idea of over time, maybe you could say, yes, it's going to cost us a lot up front, but it's going to improve health. And we all believe that, right? Improved access and reduces costs long term. But whenever you increase access, it's going to cost to begin with, right? Expansion of Medicaid costs to begin with, right? Especially because what do you find? You find people that desperately need the services. I mean, we think about behavioral health, and access to behavioral health in your home is going to bring people in that needed behavioral health all along, but probably weren't going to go to an office to receive it. So it's those types of issues. Sometimes the right thing and the thing that makes us healthier and better access and all the things we want to see as a society also cost more, at least in the short term. And that can be a reason why they don't happen.
Exactly. All right. Well, listen, it is the top of the hour. So I do want to thank Richelle for offering her expertise. And please make sure that you look at those slides on Box, because there's some links there that will be very helpful. We just want to remind you that the next ECHO will not be until August 11th. Please let us know if you have some ideas that will help you, because we're trying to, make sure that these ECHOs are good for you. Thank you for attending. We appreciate it, and go out and make it a great day. Thank you and goodbye.